and welcome to the Global State of Steatotic Liver Disease panel. I'm Larry Holden, President and CEO of the Global Liver Institute and host of the Global Fatty Liver Day campaign. Today, we're bringing together leaders from across metabolic health and liver disease to take a step back and to look at where the field stands and where it's going. Now recognized as one of the most common chronic liver conditions worldwide, steatotic liver disease is reshaping how we think about prevention, diagnosis, and care. This conversation will highlight some of the most important progress in the past year and what it means for people living with liver disease every day. And now I'm pleased to welcome Dr. Amit Gupta from the Global Metabolic Health Alliance. Dr. Gupta will be leading today's important conversation. He is a physician leader and global advocate in diabetes and metabolic health with a strong focus in prevention, implementation science, and health system strengthening. He serves in key leadership and advisory roles across national and international platforms, contributing to clinical education, policy dialogue, and population health initiatives. Finally, don't forget to check out our educational materials, share our toolkits, and add your event to the heat map. Share your story on our website, globalfattyliverday.com. Thank you for joining us and being part of the Global Fatty Liver Day movement. Dr. Gupta, the floor is yours.
Thank you, Larry, for the wonderful message on this very important day that is the Global Fatty Liver Day, and for the kind introduction of myself. So here we have three global experts with us, and we are going to talk about this very important topic today, that is the steatotic liver disease, how the things are changing, and what is the responsibility of healthcare professionals, what is the responsibility of the advocates, patient advocates, and the policy people today. So we will discuss all this. Before that, I would like to briefly introduce our panelists today. We have Dr. Jackie Malouf with us. Dr. Jackie Malouf is currently the Vice President of the International Diabetes Federation. She is also the founder and president at the DIALAB. So welcome, Dr. Jackie.
Thank you.
Have with us, thank you. We have with us Dr. Saima Ejaz. Dr. Saima Ejaz is from UK, and she is a specialty doctor in hepatology and lifestyle medicine physician. She is the lead for the public and the patient involvement and engagement at the Institute of Liver Studies, King's College London, and King's College Hospital, honorary senior lecturer, and the School of Immunology and the Microbial Sciences at the King's College London. So welcome, Dr. Saima. And then we have with us Mr. Peter Ernst. And Peter is a very well-known figure in the field of hepatology. He is a very passionate advocate and the public health advocate and the advocate for the liver policy. So welcome, Peter.
Thank you.
One beautiful thing about this panel is that all the three panelists, they were present at the World Health Assembly, and they saw this moment where the resolution was adopted by the WHO. And this is really a milestone, a landmark decision. And now we know that the global NCD agenda now includes the steatotic liver disease as well. So I think this happens to be one of the most exciting times in terms of the liver disease. I had the privilege of being part of some of the conversation at the UNGA meetings in New York, and then in Barcelona we had some of the meetings during the ESL meeting. So I think this is a very exciting topic. So let me just bring some context and the context. So this year is very, very pivotal, and it talks about the liver health because of the adoption of the steatotic liver disease in the NCD agenda by the World Health Organization. What this means? This means that now the broader NCD aspect will have liver into this, and then we have to think that how we integrate the diagnosis of the fatty liver, management of the fatty liver, advocacy about the fatty liver, and how does we ask our governments to change the policies so that the people living with steatotic liver disease, they are able to get the maximum benefit. So with this, I would like to start the panel discussion. And my first question, this is an opening question, and I think all three of you are welcome to comment on this question. So my question to all the panelists is that when you look at the global landscape of the steatotic liver disease today, what has changed most dramatically in the last 2 to 3 years, and regarding how we think about the fatty liver disease? So how does the thinking about the fatty liver have changed? So maybe we go in the same order, Jackie, then Saima, and then Peter.
Thank you, Dr. Amit, and thank you, GLI, for having me today on this important panel. Let me start by saying that I personally see this moment as a turning point for liver health. Let's agree on that before we start talking. And personally, through our long-standing partnership with GLI as Dialab and GLI, it's been 5 years in a row that we partner on this important day to shed the light on the importance of awareness. So through that, I can see the momentum. I can feel it, especially that I was present in Geneva and I was also a guest speaker at the distinguished panel with GLI the day the resolution was adopted. So for me, the biggest shift is that fatty liver disease is finally being recognized for what it truly is, and not simply a liver condition, but a metabolic health issue with all what that means and what it entails as well. So for too long, the liver disease um, lived in silos. It was treated in silos. It was seen as a simple disease, although we all know here, all the people present here, we know how strongly it is interconnected with many of the other diseases, especially the NCDs. And I personally, through my experience, have witnessed how strongly it is connected to diabetes, for instance, and to many other diseases. And I do think that one major milestone has been during the WHA 79 in Geneva. It's a very, very big milestone that we need to build on and take it as a groundbreaking to go on and look forward. It's not our goal, it's the starting point for what has to come after. Resolutions are ink on paper if they don't get implemented. So we need this moment to elevate the liver disease onto the global NCD agenda and create this momentum of accountability for the countries to integrate it into the broader health strategies. We know there are gaps. We know there are challenges. I will not go into those, but I would like to say that people do not fail the healthcare systems. It is the healthcare systems who fail people when they miss opportunities to detect the diseases early.
I completely agree with you, because now the real thing is that how do we go forward after all this resolution has been adopted? So this is a big responsibility. So Dr. Saima, what is your opinion on this?
So thank you, Amit. And yes, it was a pleasure to be, I think all of us were together, and it was an amazing day and opportunity. I think it has been a significant shift, and the whole process has been, I think, groundbreaking, not only for the patients. I think it has been groundbreaking for the healthcare system, because now we are discussing. So first of all, we have taken MASLD as not as just a liver disease. It is like the manifestation of the metabolic disease, which is very important. So we have taken it in the same spectrum as diabetes, cardiac disease, and rest of the metabolic spectrum. But the other important thing is that from changing the definition of what the people or the patients or the clients or whatever you say, they don't have to something what is driving the disease. We have been discussing again and again what are the underlying processes which is driving the disease. So now the focus has been on that, and I think that will change how we practice medication, and all the rest of the field will be changed because the drugs are coming and we have to focus on the cause. And I think this has also highlighted that it has to be not a reactive medicine, it has to be preventive. So we have changed the course. And I think Peter is going to highlight next from his views, but I think this has been an amazing year.
Yes, thanks, Dr. Saima. Peter, what are your thoughts on this?
My thought is I agree with Dr. Sharma. The WHA 79 was a great event. I was just grateful to be invited with such learned people in their professions and to be there as a patient advocate. My past history has been that earlier diagnosis is the way forward, because when I started my journey, it was just noticed as a fatty liver. And it was just said, oh, you just got a fatty liver. And then I thought, well, yes, I'm a bit overweight, and that probably explains it. But earlier treatment might have been more beneficial, earlier stage of treatment. I mean, I went on, and obviously they observed the fatty section getting larger, and it got too big. So then I went to Royal Free, and then I had a liver dissection. But now, touch wood, I feel good. I'm very grateful for the NHS and the doctors, you know. So, but I'm very keen on early detection to prevent people from going through that. And I think, you know, which leads on to early treatment.
So we have some of the comments in the chat box, and it is time we can say hello to Ivy Ahmad. We can say hello to Nohat Lee. Thank you for joining, Sneha. Thanks. Hello to you, Pedro. Thanks for sharing information about Dialab. Then we have Oluvole for the comment. Hello, Oluvole, Pankaja, and some of the comments from one of the doctor from Dr. Ajay Gupta. And I think this is very important. And this question I would like to ask to Peter, because for the last 5 years, the terminology regarding the fatty liver has changed multiple times. So as a patient advocate, as a public health advocate, how do you see that this terminology can change? What does it changes for a patient or a person with the lived experience?
Well, I think early treatment, mentally, you feel like you're in good hands. I mean, at the time, to be quite honest, I didn't even know I had the disease. I felt great. I think what was probably the worst bit of it, being told you had this disease, you know, and I'm thinking, I can't imagine it. You know, I don't know why. My liver's disease came from hepatitis C, and the hepatitis C was cured. But this, then it led me to liver disease. So how can it change? Again, I keep beating the drums about early detection, you know, at the earlier stage where it puts people at ease. They know they're in good hands. And if they can hold their lives together without invasive treatment, it's got to be a positive thing.
Rami,
So
would you allow
yeah.
me a comment here, please?
Yes, please. Yeah.
First of all, thank you, Peter. It's so important for us to hear the lived experience, to feel with you, to hear what you have to say, to hear your voice. I don't think ever a panel is complete without the presence of a person with lived experience. And regarding the naming, and I don't think it's so relevant how you call it, how you name it, muffled, MASH, NASH, a fatty liver day, or steatotic liver. It's all a scientific term. As long as we have empathy to the people living with the disease, as long as we don't stigmatize people, I think it doesn't matter what the name or what the letters, what the acronym is, as long as we show respect and care for the people living with the disease. And I believe Peter agrees with me. Do you, Peter?
I certainly do. I certainly do. Thank you.
So I would like to add to this, Dr. Jackie. What has happened is that when we were simply using the term fatty liver for years, probably there was some kind of, you can say, sentiment related to the term fatty liver, that no action was happening on the fatty liver. So probably the medical community was also taking fatty liver as something benign. So overlooking the condition, not actually talking about it. And we have seen this for years, because on ultrasound, it was regularly reported by a radiologist, fatty liver grade 1, 2, 3. And so, but we always said that, yes, nothing needs to be done, because it was fatty liver is fatty liver. That's it. But I think the shift in the terminology now, coming with the mast cell and the steatotic liver disease, actually puts fatty liver into a spotlight. Yes, it is a medical condition, and we need to take care of that, and we need to further assess because there can be consequences of the fatty liver. So I think this is from my perspective, but you are also right. Sometime the terminology may not matter that much, but I think here it needed a shift because the condition was overlooked when simply it was called fatty liver, but now being called mast cell and SLD, probably the medical community is paying more attention to it. So
And
this is
Amit,
my
I
thought.
will just add to it that, and although it was non-alcoholic, but because the name alcohol always came, there was always a stigma attached. And the patients have to keep on saying that we don't drink alcohol. So, it's just how you read sometimes just the labels and don't go beyond what is said. So I think it was a good move that we have moved beyond that it is a metabolic disease now.
So, Saima, you simply read my mind because I was just about to ask you that now when we talk about mast cell, are we simply talking about a liver disease or are we talking about a broader category that is the metabolism? And so, is it simply a mast cell or it is we are looking at some bigger picture in this?
So what is very important how we have now defined MASLD or the metabolic steatotic liver disease. Now the definition itself uh, encompasses that either you have high BMI, you have diabetes or pre-diabetes, high blood pressure, high cholesterol, all the features of the metabolic dysfunction that we all have been seeing for years. Patients never present as an isolated. So my first training was in diabetes and metabolic medicine, and then I've moved into hepatology. I've never seen patient coming with one organ manifestation. It's always like, it's not a linear relation. It's the same case like when we see fibrosis, we don't see like F1, F2, F3. Usually what we see is a spectrum. So now in the spectrum of the metabolic syndrome and changing the definition, liver disease is just part of that whole process. So to manage the patients, even it has become much easier because you don't just have to focus on the liver manifestations, you also have to take into account how you manage the rest of the metabolic features.
Very well said. And bringing into diabetes also into conversation. So, Jackie, you have been at the forefront of many diabetes advocacy programs at the IDF as well for many years. So, it has been highlighted that for many years the liver remained a missing piece when we were designing the pathways for management of the diabetes. So, what is your opinion on that?
Very important question. Thank you for giving me the opportunity to talk about that because historically we noticed that diabetes care pathways focused heavily on obesity as a risk factor or complication and eyes, kidneys, feet, CVD or cardiovascular risk, many other things, but never on liver because it became like a forgotten organ. Luckily, not anymore, especially not after Geneva and the adoption of the resolution. But let me tell you, part of the problem, I think the main problem, is that liver disease is silent, but so is diabetes type 2. So, being a silent disease should give us a chance for more awareness, for more prevention, not the opposite. But I think what was happening is that diabetes specialists, on one hand, assumed that liver disease belonged to hepatologists only, and hepatologists assumed on their turn that diabetes clinics would identify the risks. So people with SLD fell in between specialists. When we say we need to stop the silence the diseases, it's exactly to remedy what was happening and to broaden the spectrum. And I think it comes later on in the conversation where we discuss that we don't need to reinvent the wheel, that the primary healthcare centers exist in every country. And if we add to those the liver screening, we don't need to reinvent a whole health system. It just needs some adjustment, and we will be doing every person living with a liver disease or at risk of it, we will be doing them a huge favor. And yes, through my work at Dialab for like 16 years now, over maybe, and 5 years serving on my second term as vice president with IDF, I've come across a lot of comments throughout our campaigns. And I've noticed how it was kind of in the shade, the topic of liver. Even when we started in Lebanon, the first time I remember I contacted universities and municipalities to hold an event to talk about the interconnection between diabetes and liver diseases, everybody was like, why liver? You are a diabetes organization. And that's how it started. And I was very pleased to see that from the first year we started, we have come a long way. And I'm very pleased to say that now no one gets shocked when we say we are a diabetes organization, but we partner with a liver organization. It has become somehow the normal thing to do because overall the metabolic health is what we all care about, and this is our goal. So the question is not any longer whether we should be screening or not. It is how quickly we can integrate liver health into the routine of diabetes care.
So, Jackie, I think you know that I understand it in a very right, and I can feel this because the idea of the Global Metabolic Health Alliance is also that we because no longer we can work in individual excellencies, but we have to come together to make that individual excellence into collective efforts and the collective excellence and the collective output as well. So that is why when we were partnering with the Global Liver Institute, so it come as a natural partner that let us talk about the metabolic health. And the next few minutes we are going to spend on this only, talking about the can we connect the dots across the metabolic health spectrum. And so my question to again anyone can come in and answer this. If we are designing healthcare systems from scratch today, forget about everything, would we even separate obesity, diabetes, cardiovascular disease, and liver disease into different silos?
I would say, I mean, probably not. I wouldn't it's not meant to be working in silos. It's like, how you work together collaboratively. And also we have been proposing this in our, so currently I just actually came out of our 60th anniversary at King's for our Institute of Liver Studies and Professor Roger Williams. And we were seeing from how we have progressed in the last 60 years in the disease diagnosis, an amazing work, but still the multidisciplinary clinics in hepatology is something that we have been discussing but not implementing. It will be amazing if a new health system has to be developed from scratch. It will be great that in a jointly manner, you sit, the hepatologist sit with the diabetes specialist, cardiologist, nutritionist, mental health experts, and everyone together, and the patients in one sitting get and patient advocates as well. They should be sitting there and giving us what is missing in this clinic, and that's how we should work together. So I would say no, definitely we should change, and community hepatology is a big thing. So we are also talking about how we can work actually with the primary care physicians together instead of primary and tertiary totally different areas.
As you mentioned earlier in your comment, Saima, you mentioned that it is time that we think more about the preventive care rather than the reactive care. And when the focus shifts more on the specialty care, then probably we are waiting for our patients to become that sick so that they go to the specialty care rather than intervening early to prevent the events to happen. And I think this is a right approach, and I can see many questions and comments. I will take them as and when they fit into our conversation. So one of these is that now we closely connect obesity as well as the liver, mast cell and the steatotic liver disease, and we want to say that one of the treatment available for the mast cell or the steatotic liver disease is the weight loss. So how do you see this? And Peter, you can answer that. Jackie, you can answer that. So are we finally entering an era where liver outcomes are considered alongside the weight outcomes?
Can I make first a comment on
Yes,
what you
please.
asked Salma and what she responded? I totally agree. And as I mentioned earlier, no need to reinvent the wheel. Primary health care exists, primary care for diabetes exists. What we need to do is integration. I think the word I heard the most in Geneva during every single symposium, panel, roundtable I've attended is integration, breaking the silos. So there are several steps that probably Salma knows better than myself to talk about. But what I would say and what I would like to see happening is that it should become as normal as checking your blood pressure. This is as simple as I would like to put it. Now, yes, barriers do exist, and we have the time constraint in clinic, we have the limited awareness, and in many countries, the primary care providers still lack confidence of interpreting the liver risk. That's something we will not dive into, but I want to call your attention that all those challenges are multiplied in low middle income countries, and especially in those areas in conflicts or humanitarian settings. I think those who have heard me speak will get tired of hearing me talk about this, but I can never give my opinion without letting everyone reflect on this point. If we consider in advanced countries, in countries living in peace, without conflict, without displacement, and yet they have so many challenges with their health system, just stop for a minute and think what would be that case and how many more challenges we have in a country where we have to think about electricity cuts, where we have to think about the bombing, when we have to think about the whole infrastructure of the demography changing due to the displacements and so on. So equity is something critical we need to think of. And we cannot create a future where the advanced diagnostics and therapies are available only for wealthy people. We should not only we cannot, we should not, because this is a human right. It's not a luxury, and the access must be global. So building on what you said, so I've heard many people making comments when we were doing screening during a campaign we did, I believe, 2 years ago on Global Fatty Liver Day in Tripoli, in the northern part of Lebanon, where we had a huge number of displaced population and underprivileged ones. I remember in the same context, but of course it was happening in Arabic, someone said, like, if you explain things to me, I'm able to understand. If you point out the connection between my diabetes and my high risk of having liver disease, I will understand and I will act. But if no one points that out, how am I supposed to know? So this gives me a frustration in one hand, but more so, it gives me satisfaction. It tells me we are on the right path. And through the awareness campaigns, we are doing what needs to be done by telling people what is the connection, what are the risks, but raising the level of awareness in order to prevent and in order to prevent the complications of the disease if it exists.
Right. So, Dr. Jackie, I completely agree with you, and what you have mentioned truly resonates with all of us, I believe. And the healthcare systems are designed. I think we need a rethink, and we need to integrate at least these 5, 6 non-communicable diseases, which falls into the metabolic health domain. And so, Peter, let me ask you from the patient's perspective, because the same person is having diabetes, obesity, fatty liver, cardiovascular disease. And so, what do you expect from the healthcare system? Because I believe that we are navigating through different specialists, different resources, and hearing from the hepatologist, reduce weight, then obesity specialist, reduce weight, diabetes again, do more exercise, change lifestyle. So, how do you see what comes to your mind when you navigate through such a healthcare system?
I think it can be disjointed. I think if it was in one silo, that it would be a smooth journey through your treatment. And also, any underlying diseases may be spotted too, because you could drop off the edge with another department. And I think for the patient personally, the smoother their journey in treatment, you know, the mind and that is just better for them, the outcome.
Right.
And
I think,
Amit,
yeah, please.
sorry, just coming to the obesity part of the question, and I think, Peter, that's very relevant because, we keep on saying, and we have been, the correlation between the fatty liver disease and obesity, it has been so strong that we keep on, there has been always from the clinical health team a sort of judgment that, it's the patients who are not eating the right way, who are not doing the right exercise. So it's like a sort of I wouldn't say a culture of blaming the patients. It has always been there. And now with the new drugs coming, which are already approved by the GLP-1s, again, we are targeting, it's a one organ disease. Is it one organ disease that we are trying to manage? Or we are looking at the outcomes in terms of the whole cardiometabolic prevention? I think this is so important because MASL patients, the data shows that it's not the liver fibrosis which ends up having more complications for the patients. It's mostly the cardiometabolic outcomes for those patients, which are the consequences are not good for the patient. So I think with the right sort of management, and I would again come back to one important thing, raising awareness. And I keep on giving this a work that I did in Southeast London. For the MASL population in high risk, diabetes and high BMI, the average BMI was 32. And 90% of those patients thought that this was normal. So this means there is lack of awareness, not only in the healthcare system, but we take obesity as a normal variation. I think there where education and that has to come because you won't have signs and symptoms. So you have to, it's our duty to give enough education to the public that, it's not normal to have this BMI.
Salma,
Right.
I have to say thank you for mentioning that because you are putting under the spotlight our role as like Dialab, organizations like Dialab and GLI, because we work on education, we work on raising the level of awareness, and we believe in that it works. It does work. We have seen the impact, we have seen the results, and it does work. So thank you for bringing that up.
So I think Dr. Jackie, congratulations to Dialab, congratulations to GLI, and we are happy to contribute to these conversation as a GMHA, as IDF as well, where we are talking about different perspectives. So let me just simplify the conversation for the next few minutes, because many of the people who have joined us, they are not from the medical background. They also want to understand what the fatty liver is, how they should be screened, how they can get to know that they have fatty liver, and once they are diagnosed with the fatty liver, then how they should plan their follow-up, what should be done. So let me just ask you, Saima, maybe from the clinical background, that suppose what are the tools by which one can get screened for the detection of the fatty liver, and how do we explain this to someone who is having fatty liver?
Yeah. So first of all, I will mention, Amit, there are very good questions from our audience. So I've been trying to read them, and they are amazing. I think there is Dr. Ajay Gupta is there as well. So he's asking a lot of amazing, and there are other people asking amazing questions. But let's go back to answering what you have just asked me. So it is the non-invasive testing, and we have guidelines. Like any other disease, we have simple guidelines which we have to follow. And the guideline starts with a basic blood test, which includes 2 of the liver function tests, so ALT, AST, then your platelets and the age. We call it as FIB4, but that's the basic test that the primary care physicians have to do it if they are suspecting that the patients have any liver disease. Now, because it's a silent disease, it's usually picked up incidentally. They go for an ultrasound or they go for something else. But as a healthcare professional, if you think that the patient has high BMI, have diabetes, do check the liver function test. So that's the baseline. Once you get the blood test done, then it's the imaging, which is either ultrasound or it's the liver scan or elastography. So we do that, and that gives you a baseline. If that is normal, the patients don't need to be seen in the hepatology care. They can be managed by the primary care with the advice of lifestyle medicine. And there was one question which was like how much weight you need to lose. Liver regenerates, liver heals. So if you lose weight for the fatty liver disease, it's around 7 to 10%. You can actually not only lose the fat in the liver, you can also reverse the fibrosis. So 7 to 10% is the guidelines to lose weight with the lifestyle changes, which can be very helpful.
And let me say that 7 to 10%, the same thing happens with people with type 2 diabetes. This is the exact recommendation because when they lose 7 to 10% of their total weight, they don't need to become models. It's a simple 7 to 10%. And that gives them the bracket of lowering the HbA1c, which is the ultimate goal, and they will feel much better. So it really will help the health overall, and not just a liver condition or diabetes or cardiovascular. The overall health will get much better if people are able to, lose that 7% of extra weight if they have it.
Right. So I think let me put it in a more simple way. So people can get to know about the fatty liver either incidentally or when going for an ultrasound or some other testing. They're told that their liver is fatty or the fatty liver is there. The problem with the fatty liver is that once you have a fatty liver, then it is a risk factor for the fibrosis of the liver, and sometimes this fibrosis can progress to the carcinoma of the liver as well. So liver cancer can develop. And these things can be accelerated by the presence of the obesity. Sometimes they can be accelerated by the presence of the uncontrolled diabetes as well. So that is how the entire metabolic system is created. So once you are diagnosed with the fatty liver, your doctor wants to know that whether you are at risk of progression to any of these complications. And can we bring you back to the normalcy? Can we bring you back from the fatty liver stages, advanced stages, to the less advanced stages and to the normalization? As Dr. Saima pointed that liver heals, liver regenerates. So even stopping alcohol intake, reducing weight, managing your diabetes, controlling your lipid levels, all these factors, they come together and they can help you in healing your liver. There are certain tests which your doctors will decide, like ultrasound scan, then you have FIB4 score, then there are many other non-invasive testing also. You go for the liver stiffness measurement, and then the doctors will decide that how frequently you need to do these tests in different clinical settings. And this may vary from age to age, and this may also vary from presence of the other background illnesses. So this is just to give a fair idea about why the fatty liver is important and why we are talking about this fatty liver. So we are.
Amit, I will just add one more thing,
yes,
that when
please,
we are
please,
talking
Sarma.
about lifestyle medicine, diet and nutrition, we just forget about the other pillars of lifestyle medicine, which is you have to be the stress management, the sleep management, which is again very much related, the emotional connectivity and avoidance of harmful substances. But now in the guidelines for the first time, we have added and based on data and research, what are the foods and what are the things which really help in resolution of fatty liver, which is the Mediterranean diet, more fruits and vegetables, less processed food. So they are now part of the guidelines. So, if the healthcare providers are giving this information to the patients, if someone knows that this can end up into having a liver failure, why wouldn't they change it? And Peter, what do you think? If someone would have told you 20 years ago, change this to this healthy diet, wouldn't you change everything?
Absolutely. I mean, I was once told that when you look at your food, and the longer the shelf life is, the worse it is for you. It's because all the goodness, there's the nutrients in that. So, and being told at an earlier stage about your liver, you can become more active. I go to the gym now, I go swimming, and I do feel good. I'm 73 and I'm still working. So, and it just makes me positive, and I'm just grateful. Just grateful.
Thank you, Peter.
If I could add just a little thing, because I am from the Mediterranean, I am from Lebanon, and one more thing I would add to the healthy Mediterranean diet. Yes, it is, but we need to always apply the moderation. System, because even the Mediterranean diet, if it's not looked at with moderation and consumed with moderation, it cannot be good. So my advice would be to look at your quality of life overall. Follow the moderation system. Do exercise. You don't need to be an athlete. Lose a little bit of weight, build your muscles, and try to eat healthy. And you just said something, the golden rule: the longer the shelf life, the more you need to stay away from those, because they are super processed, ultra processed food. So if our ultimate goal is quality of life, I think we can do much better than to focus on just losing weight, or focus on just doing so many hours of exercise. Let's look at it from a broader spectrum, and for our own good. And I implement that in my own life. I never weigh myself every day. I never focus on how many hours. The day I can't go to the gym, it's perfectly fine. When I eat in moderation, and it makes your life easier, but a much better quality of life.
Yes. So thank you, Jackie and Saima, because that lifestyle perspective is very, very important. And lifestyle, as you mentioned, is not simply about what do you eat and how much active are you. There are many other components as well. As you mentioned, stress, sleep, and the other biological factors, they are equally important when it comes to lifestyle. And what I have learned, that lifestyle medicine has evolved over a period of time, and it is not simply, it cannot be preachy anymore. I think we need to learn. We all need to learn that how do we actually execute it in our clinical practice? How do we do it in day-to-day practice, and bring it into our conversation and help our patients with the actual lifestyle changes? So thank you for bringing that up. So maybe now, next few minutes we can spend on the World Health Assembly resolution. So what does it mean to the healthcare professionals? I will ask this to Saima. What does it mean to the organizations? I will ask this to Jackie. And I will ask Peter, what does it mean to the patient advocates? So Saima, what does it mean to you?
So I think Jackie nailed it in the beginning that you can pass hundreds of resolution unless you have the implementation in the healthcare system in the government levels, it wouldn't be effective. But at least we have taken the first step, and the next step should be that we should be talking about it, how we are going to implement and change it. I think there are going to be 2-3 things which are, I think, is very important using this. It's a massive move that has been done after so many years. How can we use this working together with the diabetes, with the obesity, with the rest of the services in raising awareness? If you can raise the awareness, I think that will be. And then I was just reading, there was one comment from Diane in the chat box as well, that then having the early detection. So we are talking about all these things because we want patients to be detected earlier. So this is another thing. So now we have defined that, that it is under the NCDs. So then we should be using the same methods. When the patients go in the high risk group, what I would love to see is that they should be screened for liver disease as we are screening them for other diseases in the community.
So I think, Saima, the most important thing for the healthcare professional is that when a resolution is passed, it is adopted, it brings immediate attention, and it brings immediate seriousness to the context, and policymakers and the healthcare professionals as well as the systems. Now they see that yes, it is a part of resolution, so it has to be looked upon seriously. So Jackie, now comes the role of the organization. The first phase we have already passed with the efforts of so many organizations, patient advocates, all over the years. Now the resolution has passed. So as an organization, because you are leading one of the top organizations in the world, so what should be the responsibility of an organization, how they should take it from here?
Well, first of all, let me say that we at the International Diabetes Federation are thrilled to see the resolution being passed. And I think Peter, when in Geneva, in all his talks, mentioned how happy we are and how ready we are to collaborate. Now, wearing my hat as president of Dialab, a small organization in a small country, I think we have a bigger responsibility, regardless of our size. Now, the momentum was created by the adoption of the resolution, but it's now time for system level change. Our role in our respective countries is to, poke our governments. I can't find another word because sometimes they need to be pushed and, knocked on the door 40 times if needed in order to see some policy changes. And as I said earlier, nothing fancy, nothing complicated, just adding to the primary healthcare centers one additional screening test and integrating what we are doing together, unifying database, stressing on early detection, highlighting the common risk factors so people would understand the risks they are up against. Many people said, if I had known, well, it's our responsibility to let them know. But I think once we start, and I think GLI and Dialab have already started implementing the resolution way before it has been adopted. 5 years before that, we started integrating diabetes and liver disease, and I'm very proud and happy to say that. But for instance, take a person living with obesity, diabetes, cardiovascular risk, not the disease itself, liver disease. They should not need four disconnected health system. They should all be addressed through one health system that integrates all the diseases for the best of the population at large, especially those at risk and especially those living with the disease. So again, I want to stress on the fact that policies are important, they matter, but they only matter when they are being implemented in the right ways. And let us all remember that policies are about people. So when we keep people at heart, especially those affected with diseases, then we can implement the policies in the best way possible.
So I agree with you, Jackie, and let me just inform you for in India, the fatty liver has been part of the NCD agenda for last, even before it was moved to the UN. And so we can take pride in that. And I think now we have more work at hand. So now it is official organization responsibility is there. People are coming forward for the collaboration. So Peter, you have been pushing this and working with so many organizations and advocating for this for years. And it sounds like a big victory as well. So from here, what do you see next?
Well, I think now we see visibility, the reduce of stigma, and the early diagnosis. Now it's been recognized from the WHA, and greater access to care, and holding governments to account by poking them, as you said, Dr. Jackie, and to bring these subjects up to your local MP and that. Because I think the long term, it's beneficial to deal with a problem at the earlier stage instead of overwhelming the health system. With
Right.
complex operations and care and.
So, Peter, I completely in sync with you. So, what you say is that visibility, reducing stigma, I think they are very, very important. And I think we need more and more patient voices to come forward. And because it has been seen that when healthcare professionals demand something, probably the systems doesn't change that fast. But when the people come forward and they demand something for their own health, then the system also listens to the demands of the people. So I think more and more advocacy is needed of this, and I'm sure at the GMHA, at IDF, at Dialab, at NHS, King's College, we are all here to support each and every effort. So happy to collaborate and work towards it. There is a comment which is very interesting, and I think I would like to take these two comments. And this also tells about the future. And there is a very practical comment by Laurel, and she mentions that when you ask about 7% weight loss or 10% weight loss, sometimes it can be very, very challenging. And I do agree with that. And at the same time, even if you lose, then sustainability of weight is something which is very, very important. So, and the environment in which we live, it is full of choices which do not promote any kind of weight loss. We have so much of the ultra processed foods at our disposal. We have so much. There are so many barriers to the physical activity. Recently, I was reading one, and these barriers are not just sometimes there are gender barriers as well. For example, I just read one of the paper which mentions that the women uh, they are less likely to have access to the physical activity than their male counterparts. So these are the few realities. And again, I will take this in the same breath where we talk about the resource constrained countries. I don't like to use poor countries, but I think the countries with the resource limitations, there are issues like access. For example, if you want to do a fibroscan, the fibroscan may be widely available in countries like US and it may be available in UK. But if you talk about a fibroscan machine in some of the countries like Africa and in some parts of the Asia, then the availability and accessibility of the fibroscan to measure the liver stiffness may not be there. So I think these are the practical challenges. And when we design the next steps, probably thinking all about this is very, very important. So maybe a quick comment from all three of you on these three aspects.
If I were to say something that yes, we don't need my intention, and I'm sure Salma's intention was not to simplify the fact of losing 7 to 10%. I want to go back to that comment. It is challenging. Nobody is saying it's easy. We are saying it would be good for the overall health if that happens. Yes, we understand it can be very challenging to some people, more so to others. So it's a case by case, and it is a person centered approach. So what's good for me might not be good for somebody else living the same circumstances, but with different physiognomy, with different biology settings. I don't know how to say that. But the point is, we do understand the challenges, and no one is saying it's easy, but we would like to see it happen, to see better health outcomes in that regards.
And
Yeah.
Jackie, totally agree. But I would just add the 10% and 7% the weight loss for fatty liver disease. That's based on the data. So this was the recommendation that if you lose that percent of weight, you can actually decrease the degree of fibrosis to 1, and you can also have a resolution of fat in the liver. But having said this, I completely agree. It's not an easy task, but we are in a very interesting period of time when the first time after 50 years we have drugs approved for MASLD or the fatty liver disease. So this is very important thing to discuss. And in every country now those drugs are available. The reason is those drugs got approval for diabetes first, and now the same drugs are being approved for the MASLD. So, and these drugs have made the whole area in the field of obesity, diabetes, and metabolic dysfunction has changed because of these drugs. So if there are some patients where the BMI is high or obesity is there, according to the guidelines, they can have and they should have access to these drugs, which can then help them not only manage the metabolic part of the diabetes and rest of the conditions, but also help the fatty liver disease. And then I will again say socioeconomic is, Amit, as you said, it's a major part. But then we come back to the same thing. It's not that, you have to have expensive food. The moderation, as Jackie said, it's the quality of simple food and how much you are going to be focused on your health, which is more important.
Exactly.
I think interesting discussion happening, and we have few more minutes before we call it a day. And let me just ask you. So if we imagine ourselves in 2030, Or let us talk about in 2027, 1 year from now, when you all go to the World Health Assembly again. So WHA has done its job. They have adopted and the resolution. So what will be you asking in 1 year, and what are the quick wins which we can think of in next 1 year?
Would you like me to take that?
Yes, why not?
I liked the idea of 2030. It's a long shot, but I mean, not too far away. It's kind of around the corner. But for me, success after the adoption of the resolution would mean that we stop accepting late diagnosis as normal. It cannot be accepted. It would also mean that risk assessment becomes a routine in diabetes and obesity care worldwide. Again, not so complicated to implement, simple tweaks here and there within our healthcare systems. It would mean also having success with the implementation that fewer people would hear we found out late about your disease. You're being diagnosed late. And I would like really to see equitable access to the diagnosis. You mentioned that the FibroScan does not have the same presence, and those tests that you mentioned, Salma, that are in some cases basic, even those basic ones are not available in some areas. So yes, access is a very and key word. And most importantly, I said something earlier that I would like to stress on right now. We need to see, and I would say major capital letters, see the person living with the disease, feel with them, and not blame. Bold capital letters. No blame. We see you, we feel you, we feel with you. And since you said we have only a few minutes, I will end with this sentence that for many years we have separated obesity, diabetes, CBDs, and liver diseases because the healthcare systems were organized that way. But our biology never separated those organs. They are in one body. So, yes, it's time to stop thinking about liver disease as only a liver problem. It is a metabolic health problem, and so should be treated. And solving it requires all of us, just like we are here, many more of us working together.
Thank you, Jackie.
Amit, I will just say I would in 2030 would want not to discuss liver as a neglected disease. There should be so much awareness about it and so much work already done that we should be highlighting the contributions from the patient advocacy, from the patients and from the healthcare of the success that we have achieved in implementing all these resolutions.
Right. Peter?
I would like to see the patients being tested on a frequency like bowel cancer. Every 2 years, you do a test in the future, rather than going to see your GP and they say to you, well, if you came to see me 10 years ago, I could do something for you. Let's be ahead of the game, or let's see the beginning of something. And there are some things, yes, the patients can do for themselves too, is to keep active, eat healthy, and and that's at their hands. And yes, sometimes poverty does play a part on the sort of food they're eating. But to me, early detection is key. Keeping active is key, because we have a part to play too. We have a part to look after our bodies, and maybe have an education in schools too at an early stage to make children aware of their diets, and, keeping them physically fit in sports and activities. I think that's the way forward.
So, thank you, Peter, for your very important remark. And we are having some amazing discussion as highlighted by Kim in the chat box. Thank you, Kim, for acknowledging that. So let me just put all the thoughts together. And if you want to have a final comment, you are all welcome. So I think awareness is something which we should be doing. And today, this is the part of our awareness program only because this is Global Fatty Liver Day. And we also call it Global Steatotic Liver Day. So everyone who is listening to us today, maybe you can take out some time and talk to, it is not necessarily social media, just try to look around, try to talk to some people, talk about fatty liver, what are the consequences, and it is not simply a benign disease. So whatever you learned from today's webinar, the information which you got, just try to talk to some of your friends and the family members. And this is the true awareness. And continue this conversation. And whenever you get the opportunity, I think this is very important. Then I think education is something which is we should be continuing. So more and more educational programs, not only just for the healthcare professionals, but also the people with lived experiences, and also the preventive approach where we don't simply talk about that how do we treat, but how do we prevent. I think the focus should be how can we prevent the fatty liver, what are the steps, how can we adopt more healthy lifestyles, how can we avoid getting the fatty liver. And this is very, very important because we are not talking about something which is in only some few thousands or few lakhs. It is, we are talking about people in millions because fatty liver prevalence is somewhere around 38% as documented by many of the papers. Also, integration of diabetes, obesity, liver health, and the ultimate thing which we talk about, the cardiovascular outcome. So very often we do the cardiovascular outcome comes into our each and every sentence. But I see very less people from the cardiovascular space being part of our conversation. The prevention of the cardiovascular disease, I have never seen many people from the cardiology space coming to getting aligned with the with obesity, diabetes. So we do talk about the management, but how do we prevent? So I think for prevention, we all need to come together. And thanks to advocates like Peter, who turned their disease into an opportunity to educate others. And they took it as a mission for their life, and they talk about the awareness. So continue your efforts, Peter, and we are all here to support you as much as we can in our individual capacity and capacity of an organization. And as Jackie said, to keep asking your governments, yes, give us better screening plans, give us better screening facilities. Ask your doctor that when you go for diabetes, don't forget to ask about the obesity as well as the hypertension and lipids as well as the fatty liver. So I think these are the few takeaways which we can take from this webinar. And I think it is time, but still a final comment from the Jackie, Saima, and Peter.
Yes.
Before I conclude. Yeah.
First of all, thank you for having me on this panel. I would like to thank all the attendees and all those who would also watch the recording later on. And I would like to say, to finalize, that we each have a role to play, whether in the implementation or in making our health system better, be it healthcare professional, be it a person living with a disease, or be it the organizations. So if we all play our role as we should, I think integrating that would be the best outcome we can dream about. Thank you.
And I would just add, now we are in a different, moving to a different time and place where we are talking about personalized and prevention. I think that, covers the gap between the clinical health delivery and the patients. So the patient should be so much made aware and educated by the healthcare system and the policymaker that they take control of their health. And that would be an amazing opportunity where people like Peter is there, but I'm seeing a lot of other patients have also joined in the chat group. They should be leading this and we should be supporting them.
Peter, any comments?
I would like to thank GLI for giving the patients a platform and a voice to come to a meeting. And I'm just very grateful. Thank you very much.
So thank you, Peter. Thank you, Jackie. Thank you, Dr. Saima, for this wonderful discussion and much needed one on the occasion of the Global Fatty Liver Day. And thank you, Global Liver Institute, for your partnership. And as a executive director of the GMHA, I am also very grateful to you for having this joint webinar and bringing this information not only to one. This is a global webinar, and we call it Global State of the Fatty Liver Disease. And this is a truly global picture. And thanks to all the attendees who watched it live. And this recording will be available at the GLI platform, and we will also make it available at other platforms, including GMHA. And those who missed it, they can watch it later. And please continue this conversation. Please continue this momentum. And we are here to build this together, to address this problem together. And I'm sure together we are strong. We will be able to reach our goals. Thank you. Thank you very much.
Thank you so
Thank
much.
you. Bye-bye.
Thank you. Bye-bye.
Bye.